So hypothyroidism can be associated with amenorrhea. So what is the cause of amenorrhea and hypothyroidism? Can anyone tell me a one-line answer for that? The cause of amenorrhea in hypothyroidism. I need a one-line answer for that. Anyone?
Weight gain.
Weight gain. How weight gain can cause amenorrhea?
It's the suppression of FSH and LH from the pituitary.
Why FSH and LH are suppressed in hypothyroidism?
Because of the high TSH.
High TSH, and you can say that there is amenorrhea in hypothyroidism because in hypothyroidism, if there are low T3 and T4, what does it gonna do? It is gonna stimulate the release of which hormone?
So TSH will be secreted more, and there will be a feedback mechanism which
What
reduces
is the stimulation for TSH, for the release of TSH?
at TRH.
Yes, TRH.
Mhm.
So we'll start from the top. Basically, high level of TRH is the cause of amenorrhea because TRH stimulates the pituitary gland to produce two hormones. One is TSH and the other one is prolactin. So when there is low levels of T3 and T4, then through a feedback cycle, hypothalamus is stimulated. So hypothalamus will release TRH. TRH will stimulate the pituitary gland to produce two hormones. One is TSH and the other one is prolactin. And then prolactin will do a suppression of gonadotropin releasing hormone, due to which FSH and LH will be suppressed. So from this explanation, you can derive 2 points. One is that hypothyroidism is associated with amenorrhea, and the other point that you can derive from this explanation is that hypothyroidism is also associated with hyperprolactinemia. Is that right, everyone?
Yes.
So
Sir,
yes.
could you repeat that again?
Remember that thyroid hormone is, you need to remember the whole axis to understand this point, that the release of thyroid hormone is controlled by hypothalamus. From hypothalamus, stimulation for the release of thyroid hormone is thyroid releasing hormone, which acts on the pituitary gland. So there are thyroid releasing hormone stimulate the release of two hormones. One is prolactin and the other one is TSH. So whenever there will be low T3 and T4, it will lead to a release of TRH and thus a release of TSH and prolactin. And prolactin will inhibit the gonadotropin releasing hormone from pituitary, which will lead to a low level of FSH and LH, due to which the patient will develop amenorrhea, and due to high prolactin level, hyperprolactinemia. So hyperprolactinemia can be present in the hypothyroidism due to excessive TRH or thyroid releasing hormone. One other important condition that is associated with hypothyroidism, that is pseudo gout. What is pseudo gout? Pseudo gout is inflammation of the joint due to calcium pyrophosphate crystals. True gout is due to deposition of uric acid crystals or urate crystals, and pseudo gout is due to deposition of calcium pyrophosphate crystals. So don't forget these associations: amenorrhea, hyperprolactinemia, and pseudo gout. These are the three conditions that are associated with hypothyroidism. How you are going to differentiate between pseudo gout and gout? The first thing is that with pseudo gout, the features of hypothyroidism will be present, such as constipation, bradycardia, weight gain, dementia or depression. These features will be given along with arthritis of knee joint, which is the most common joint involved in pseudo gout. And the other thing by which you can differentiate between gout and pseudo gout is that the presence of birefringent crystals. If on synovial fluid analysis birefringent crystals are present, then your diagnosis will be pseudo gout. So arthritis with features of hypothyroidism, pseudo gout. Arthritis with features of hyperuricemia, true gout. Synovial fluid analysis shows birefringent crystals, pseudo gout. Uh, Synovial fluid analysis show monosodium urate crystals, true gout. Is this point clear to everyone? Three important conditions that are associated with hypothyroidism include amenorrhea, hyperprolactinemia, and pseudo gout. The cause of amenorrhea is hyperprolactinemia, and the cause of hyperprolactinemia is high level of TRH or thyroid releasing hormone.
Can you please repeat the difference between pseudo gout and true gout?
Clinical difference or laboratory finding difference?
Laboratory finding, please.
Yes. Can you see this blue highlighted area?
Yes.
On aspiration of synovial fluid, there is birefringent crystals. What does birefringent mean? That the crystals shows a double refraction of light. So the crystal is showing double refraction of light, then they are called bi mean two or double birefringent crystals. Then it is pseudo gout because calcium pyrophosphate crystals are birefringent, while uric acid crystals are not birefringent. They are monorefringent.
Right.
So if on synovial fluid birefringent crystals are present, then it is pseudo gout. And if monorefringent crystals or monosodium urate crystals are given, then it is true gout.
That's right. Thank you.
And the other differentiating feature is that with pseudo gout, other feature of hypothyroidism will be present.
Right.
While in gout, there will be history of hyperuricemia. So pseudo gout, amenorrhea, hyperprolactinemia, and autoimmune diseases can be associated with hypothyroidism because hypothyroidism or Hashimoto thyroiditis is itself a autoimmune disease. So other autoimmune diseases such as recent disease, pernicious anemia, vitiligo, and DM1 can be found in association with hypothyroidism. First line treatment for thyrotoxicosis in general. What is the first line treatment for thyrotoxicosis in general? Can anyone tell me?
Carbimazole.
Yes, carbimazole. So if someone has low TSH and low T3 and low T4 on thyroid function test, then what will be the diagnosis?
Low TSH, low T3. Subclinical hypothyroidism.
Low TSH, low T3 and low T4. All are low. In subclinical hypothyroidism, TSH will be high and not low.
Right. So everything top.
Anyone else would like to answer this one? T3, T4, TSH, all are low.
In secondary hypothyroidism.
Yes, secondary hypothyroidism.
And
Okay,
it's same for sick euthyroid as well.
yes, I was going to ask the next question, that
Sorry.
low T3, T4, and TSH in a sick patient or in a patient admitted in ICU, then the diagnosis will be sick euthyroid syndrome.
Sir, please repeat this.
Low T3, T4, and TSH, secondary hypothyroidism. Low T3, T4, and TSH in a sick patient, sick euthyroid syndrome.
Okay.
Okay, raised TSH and normal T4. Now, what is the diagnosis?
So there could be two, one subclinical hypothyroidism and poor compliance.
Yes, if the question stem mentioned that the patient was diagnosed with hypothyroidism or primary hypothyroidism few months back, and he was started on levothyroxine, and now his TFTs are performed, which shows a TSH raised and normal T4, then your answer will be poor compliance with the levothyroxine. And otherwise it will be subclinical hypothyroidism. So raised TSH with normal T4 is subclinical hypothyroidism. Raised TSH with low T4, then what will be the diagnosis?
TSH low.
Hypothyroidism.
Primary
Primary
hypothyroidism.
Primary hypothyroidism.
Primary hypothyroidism. Dr. Joe, Dr. Shafraz, and Dr. Abdullahi, are you guys following me?
Yes, sir, we
Yeah.
are.
Yes, that's good because your exam is near, so you need to.
Following, Doc.
Okay, okay. So a female present to you with postpartum thyroiditis in hyperthyroidism phase. How will you manage this patient?
Sorry, say again, please.
A postpartum breastfeeding woman presents with palpitation, tachycardia, and low TSH. What is your diagnosis?
Hypothyroidism.
Thyroiditis. Thyroiditis. So it
Okay,
will be
one answer
resolved.
is thyroiditis. Someone is saying, so it is postpartum thyroiditis with hyperthyroidism. Remember that postpartum thyroiditis and subacute thyroiditis, they can cause hyperthyroidism as well as hypothyroidism. So a postpartum breastfeeding woman presents with palpitation, tachycardia, and tremors. So it is postpartum thyroiditis, and the feature of hypothyroidism is present. So it is postpartum thyroiditis with hyperthyroidism because her TSH is low as well. So how we are going to manage this patient?
You don't treat it, right?
Yes, we will only treat symptomatically.
The symptoms.
So what are the symptoms of this patient?
Tachycardia.
Tachycardia, palpitation, and tremors. How
Yeah.
these symptoms can be managed?
Like
Propranolol.
propranolol?
Propranolol, that's right. Now, if the same female present to us with breastfeeding female with low TSH but no palpitation or tachycardia or any sign and symptoms, then we will choose no treatment required. And if the same female present with uh, high TSH or features of hypothyroidism, then we can consider treating it with a trial of levothyroxine for 2 to 3 months. In hypothyroid phase, in postpartum thyroiditis, treatment with levothyroxine can be considered if the patient is symptomatic.
Even
This
if
is
she is
even
asymptomatic.
while
Sorry,
What?
you can't please.
Doc-
I'm
Yes,
just
yes.
asking if
Dr. Shafraz, you can speak first.
no, Dr. Msart can go ahead, then I'll ask my question.
sorry, my question was like if the patient was asymptomatic with postpartum hypothyroidism, will still we treat the patient?
No, no. If patient is asymptomatic, then no treatment is required.
Thank you.
Yeah, I wanted to ask if it's safe to use levothyroxine while the patient is in the lactation phase while she's breastfeeding her child.
Yes, thyroxine is not excreted in breast milk.
Okay, that would just be carbimazole, right?
Yes, carbimazole is excreted in breast milk. Even propyl thiouracil is excreted in breast milk, but in very, very minimal amount. So that's why in postpartum period or in breastfeeding women, we prefer propyl thiouracil.
Okay, thank you.
Postpartum thyroiditis usually resolve on its own in 1 year after delivery. Therefore, antithyroid medication, carbimazole or propylthiouracils are not needed. However, in the hypothyroid phase, levothyroxine can be used because if the patient is symptomatic, and then we have no option but to use levothyroxine. So remember that thyroid peroxidase antibodies are present in around 80% of postpartum thyroiditis cases as well. So antithyroid peroxidase antibodies are present in uh, almost all cases of thyroid diseases such as Hashimoto thyroiditis, postpartum thyroiditis, subacute thyroiditis, and in Graves' disease as well. Thyroid peroxidase antibodies are present in all of them. So whenever a question is asked in all four of them, then focus on the clinical history and findings of the patient and not on the thyroid peroxidase antibodies because they can be present in all of them. So we are done with thyroid disorders. Now we are going to do some diseases that are related to pituitary gland. Pituitary gland diseases. Remember that tumor of the pituitary gland can cause some hormonal diseases. Pituitary adenomas, they can be prolactinoma, they can be growth hormone secreting tumor, which will cause acromegaly. They can be ACTH producing tumors, which can lead to Cushing disease. Basically, there are 5 hormones that are synthesized in the pituitary gland. One we discussed in the thyroid diseases, and that was thyroid stimulating hormone. The other was discussed in the thyroid section as well. And the second hormone was prolactin, that is synthesized by the pituitary gland. Now, the release of thyroid stimulating hormone is stimulated by the TRH from hypothalamus. So all the hormones that are secreted by the pituitary gland, they have their control center in the hypothalamus. Remember this point, that the hormones that are secreted by the pituitary gland, they have their control center or they have their controlling hormones from hypothalamus. The TSH is stimulated by the thyroid releasing hormone and inhibited by the thyroid inhibiting hormone, that is also from hypothalamus. The second hormone that is synthesized by the pituitary gland is prolactin, and its secretion is controlled by the hypothalamus in the form of dopamine. Dopamine, remember that dopamine from hypothalamus has an inhibitory effect on the secretion of prolactin. So, in short, you can say that dopamine inhibits the release of prolactin. Now, the third hormone that is secreted by the pituitary gland is ACTH, adrenocorticotropin hormone. Its release from pituitary gland is also controlled by the hypothalamus. Adrenocorticotropin releasing hormone is also released from the hypothalamus, and then it stimulates the production of ACTH from pituitary gland, and this ACTH then acts on the adrenal gland to produce cortisol. So PSH, prolactin, ACTH, and then gonadotropic releasing hormone that is secreted by the hypothalamus, and it stimulates the pituitary gland to produce follicle stimulating hormone and luteinizing hormone. So TSH, prolactin, LH and FSH. Which one did I miss? Anyone? TSH, prolactin, LH and FSH, and ACTH. Yes, gonadotropins are FSH and LH, and they are releasing hormone or they are stimulating hormone that is secreted by the hypothalamus is gonadotropic GnRH, gonadotropic releasing hormone. All the hormones that are released by pituitary gland, they're inhibiting and releasing hormone is secreted by the hypothalamus. And from the posterior lobe of pituitary gland, ADH, antidiuretic hormone, and oxytocin, they are released. So this was a short overview of the hormones that are released by the pituitary gland. Now the topic is pituitary adenoma. So a benign pituitary tumor is called pituitary adenoma. The most common pituitary adenoma are the prolactinomas, pituitary adenoma that produce prolactin. The second most common is non-secreting adenomas, means they do not secrete any hormone. They are non-functioning or non-secreting adenomas. So the most common pituitary adenoma is prolactinomas. The second most common is non-secreting adenomas. And then the third most common is growth hormone secreting adenomas. Growth hormone secreting adenomas will cause acromegaly. And the fourth one is ACTH secreting adenomas. ACTH secreting adenomas will cause Cushing disease. So there are 4 types of pituitary adenoma depending upon the hormone they produce. The most common one is prolactinoma. The second one is non-secreting adenoma. Third one is growth hormone secreting adenoma, and fourth one is ACTH. So what is a microadenoma? If the size of the adenoma is less than 1 centimeter, then it is microadenoma. And if the size is more than 1 centimeter, then it is macroadenoma. Pituitary adenomas can also be classified on the basis of hormonal status. They can be secretory, such as prolactinoma and acromegaly and ACTH secreting adenoma, or they can be non-secretory. So the most common one was prolactinoma. Prolactinoma will lead to hyperprolactinemia. So what is hyperprolactinemia? Hyperprolactinemia is excess prolactin secretion. And you all know that what will happen if there is excess prolactin secretion. If there is excess prolactin secretion, FSH and LH will be decreased, which will lead to amenorrhea in females and decreased libido and erectile dysfunction in males. Also, high prolactin level will lead to galactorrhea or milky discharge from the nipples. So what are the features of hyperprolactinemia? High prolactin level can cause galactorrhea, amenorrhea, decreased libido in females, gynecomastia, erectile dysfunction, and decreased libido in males. Why these signs and symptoms occur? Galactorrhea due to high prolactin level, because prolactin stimulates the milk production from the breast or mammary glands, and also they suppress the LHRH hormone. LHRH hormone is luteinizing hormone, releasing hormone that is released from the hypothalamus. So if there is suppression of LHRH, there will be decrease in luteinizing hormone and follicle stimulating hormone, which will lead to amenorrhea in female and decreased libido and erectile dysfunction in males. What are the causes of hyperprolactinemia? Pituitary tumors such as prolactinomas is the important cause of hyperprolactinemia. Hyperprolactinemia can occur in physiological states such as pregnancy, nipple stimulation or suckling, and stress can also cause hypothalamic diseases because dopamine is released from hypothalamus, which inhibits the prolactin production. So if there is any hypothalamus disease, it can lead to decreased production of dopamine, and if there is no production or decreased production of dopamine, then prolactin level can be increased. And we have just discussed in that in hypothyroidism there can be prolactinemia. So what is the cause of what is the cause of hyperprolactinemia and hypothyroidism? Anyone? What is the cause
Sorry,
of
could you repeat that?
what is the cause of hyperprolactinemia and hypothyroidism?
You just asked this question.
Yes.
If somebody can say that. It's the TRH which is reduced from the hypothalamus,
Yes.
and then its effect on TSH and reduce
Yes.
prolactin
That's
level.
right. So a single line answer for the cause of hyperprolactinemia and hypothyroidism is high TRH or thyrotropin releasing hormone or thyroid releasing hormone causes hypothyroidism, causes hyperprolactinemia and hypothyroidism. So pituitary tumors can cause hyperprolactinemia. Pregnancy and nipple suckling or stimulation can cause hyperprolactinemia. Hypothalamic diseases can cause hyperprolactinemia. And there are some drugs. As I told you that the prolactin secretion is inhibited by dopamine. So dopamine antagonist, the drugs which are dopamine antagonist can also lead to hyperprolactinemia. Now, can any one of you give me some examples of drugs which are dopamine antagonists? Recall from the chapters of neurology. Example of the drugs which are dopamine receptor antagonist.
Haloperidol.
Haloperidol, antipsychotics. And one more example, please. Which antiemetic is D2 receptor antagonist?
Metoclopramide.
Metoclopramide.
Yeah.
So metoclopramide and antipsychotics such as haloperidol and razeperidone can also cause hyperprolactinemia. Polycystic ovarian syndrome can also cause hyperprolactinemia. So these are some common causes of hyperprolactinemia. The important cause of hyperprolactinemia is pituitary tumors, such as prolactinomas. Does anyone have any question? So features of hyperprolactinemia is in women galactorrhea and menstrual irregularities such as amenorrhea and oligomenorrhea, and in men erectile dysfunction, decreased libido, gynecomastia, and reduced fertility. So we'll end our session here today.